Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fodden. I'm the chair of Grand Rounds today. I will not be the chair of Grand Rounds next week because I'm devastated to tell you, and I know you'll be upset, that I'll be in San Diego next week. I know, it's terrible. So if anybody would like to chair Grand Rounds in my stead, then I'll happily speak to you at the end, and I can. That would be much appreciated. We have an external speaker next week coming up from London, Gay Sutherland, who's an expert in nicotine addiction, and she's going to talk about nicotine addiction and smoking cessation. It's very topical because you'll notice that outside we have a new smoking cessation sign. And there's a new public health push on how to help our patients stop smoking. So ideally I probably ought to be here, but unfortunately I'm toughing it out in San Diego, so I'm sorry about that. This week the university are here to talk about ScotGEM, which is the Scottish Graduate Entry Medical School, which is a new venture, a collaboration between us and St Andrews University and all those other people on the bottom of that slide, who you can see it's a team effort. I know very little about ScotGEM. My time in the university came to a conclusion just before it all kicked off, so I'm interested to hear what's going to go on. Jon Dowell is going to speak first and introduce the subsequent speakers, who's going to tell us all about the ScotGEM programme. Spontaneous round of applause for Jon.
Spontaneous. Yeah, right, okay, thanks. Thank you very much, Tom. Can I ask just first of all to suss out you as an audience, hands up who feels they effectively know almost nothing or very little about ScotGEM, so I can pitch where we start. Okay, a few, yeah, about a quarter. And who feels they actually understand the programme reasonably well, have been involved, probably faces I recognise in this, so yeah. Okay, so I'm going to try to pitch in the middle. There have been a few previous talks about ScotGEM, and I didn't want to repeat the same stuff, so I'm going to give you some extra sort of factual information that I think is coming out of the woodwork and looking interesting, and I'm going to talk around the timetable of ScotGEM so that if we want to talk about the implications for Dundee or Tayside, then we can focus on that aspect in the discussion. But that's not going to be the majority of the talk because ScotGEM isn't really coming to Tayside for a little while. Ellie Hothersall, as the director of the MBCHB, is here to join us particularly for that last bit because we're in conversation about how the two courses come to interdigitate and work effectively to get together going forward. So she's very keen to hear what people have to say, and so we can work on those things. We're also going to, though, bring to your attention today and talk a little bit more about two of the unique features of ScotGEM. So my colleague Andrew O'Malley, who is the Year 1 lead and is in charge of designing the case-based learning aspect, which forms the delivery platform for Years 1 and 2 of ScotGEM, which will be new to folks who work in Dundee or used to systems-based education or even more traditional systems. And Lisa Owen, well known from downstairs, has recently been designing the combined clinical interactions course, which blends the mixture of communication and consultation skills, examination skills and procedural skills into a single kind of entity, which fits much more with the case-based learning approach. So I'm going to just give you a quick whistle-stop, a quick rip through some kind of interesting stuff connected to ScotGEM. We start in September 18 with 55 students turning up. We think we're going to get them. We look like the usual eclectic bunch of graduates who are slightly different to undergraduates. The mission of ScotGEM was driven by the GP workforce crisis in Scotland, in particular in rural areas. So we need approximately 50% of our graduates to become GPs on a sustainable basis. And particularly rural areas are struggling. So Shetland, I heard recently, which has 11 general practices, 8 of those 11 are now run by the Health Board, and only 3 of them are traditional partnership models, which means the Health Board spends a shed load of money buying in and flying in locums to keep the service propped up. Rural general practice is collapsing, and unless we can do something moderately dramatic to try and improve the situation, then that may have knock-on effects to entire communities, effectively, who lose a decent medical service. So this is a real priority for the Scottish Government. Just on the right there is a little wordle that we've been evolving from consultations with different parties around ScotGEM. I think it's quite interesting, almost for what it doesn't say as much as what it does say, actually. But the tone of the focus around the key partners in ScotGEM is quite innovative and not your traditional kind of medical school approach, probably. So I'm going to give you a bit of background. We're going to talk to you about case-based learning briefly. We're going to run you through this clinical interactions course. You heard about a month ago from Maggie Bartlett about one of the other innovations, which is the longitudinal clerkships, which is the third year of ScotGEM. And then we'll give you a chance for some discussion. So just historically, there is now an international movement around the supply of rural doctors throughout the world, of which Australia and Canada have been rather ahead of the frame in the Western world, and Scotland is the first UK example of a response to this agenda. There's other schools, for instance, Bradford, interestingly, is setting up a similar initiative. So there are those following on our heels. If we look at the GP full-time equivalent count across Scotland, you'll see that it's starting to gradually tail off. I've highlighted the fact that in rural areas this is dropping off more, but if you think of the other changes that are happening in the shift of care from secondary care to primary care, etc., that reflects an increased pressure on a falling number of whole-time equivalent GPs. That's reflected in the vacant session rate. So again, if you look 2013 to 2017, we've got an increasing vacant session rate in general practice in all areas, so roughly quadrupled in that 4-year period. You can understand why the GP workforce is getting itself a little bit agitated around staffing. If we look at UK career choices of graduates, then the foundation programme surveys suggest that around, on average, 21% of their graduates from the foundation programme are planning to go into a career in general practice. Contrast that with the 50% odd that are needed. That's why there's an issue. And that permeates through the data coming up in some sort of interesting ways, I think. This has been studied in some depth, in particular this thing called By Choice Not Chance, or sometimes known as the WAS report. And this looked at the reasons why undergraduates are saying they're not interested in a GP career. And the largest by far is the repeated GP bashing that goes on in the secondary care sector. So there are some fantastic quotes. Oh, you're too clever to do general practice. You're wasted on general practice. Why would you think about that? And many students report not declaring an interest in general practice to avoid those sorts of comments from teachers and colleagues. And there's a whole range of other things. So there's many reasons. It's a multifactorial issue, but ScotGEM is being put up as one of the approaches to helping to resolve this. Clearly a rather kind of long-term game. There's been some work done around Scotland, in particular looking at FY2 doctors and the things that they said have led them to choose a career in general practice. So I won't go down those, but you can see that undergraduate experience is up the top of that list. In terms of internationally, because there isn't very much data on this from within the UK or within Scotland, there is considerable amassed data now that there are 3 core things that influence whether people are interested in becoming rural general practitioners. So one is that they come from a remote or rural area in the first place, so you have to attract applicants. Particularly tricky if, for instance, gaining science hires and advanced hires in the west coast of Scotland is more challenging because they haven't got the teachers. So you can't just skip to a different school as people do within the likes of Dundee, for instance, but just because of the geography. So there are systematic reasons why it's more difficult or less likely for people to choose medicine from those areas. You need to have both a prolonged and positive educational undergraduate experience is key, and also the opportunity to then continue your postgraduate training. So ScotGEM might address some of these two, but it's not actually going to address that. Again, further international evidence looking particularly at what it is about undergraduate GP exposure that makes a difference, and it's the number and length of primary care placements, and in particular this thing that's been being piloted in Dundee for the last couple of years, longitudinal placements. There is a qualitative difference in the educational experience which general practice seems particularly able to provide, more on an apprenticeship or like a GP training model, which means the students are not rotating so fast around different areas that they are largely observational. This allows students, typically over about the first 3 months, to actually become useful at delivering care in the practice. People get to know them, know what their limits are and what it's appropriate to ask them to do, and then start to use them in that care process, which is an immensely rewarding educational experience for the individuals and leads to some fascinating outcomes, things like following mums through and delivering their babies when they saw them when they first presented as pregnant. Just a little bit more data. I can't resist floating past you because I've been involved in setting up this UK Med project. So this looks at who chooses to be GPs depending on which medical school you come from, and you can see that there's quite a lot of variation. Cambridge and Oxford down here stand out in that regard. Whole York, that's Bradford, of all strange places, and Dundee's kind of middle of the road. Point here is that the educational selection and experience you get alters things quite a lot. I was stunned by this when I was looking at it. A bit more UK Med data here. I'm going to have to explain this to you a little bit. So this is a multi-level model data. If you look up here, we've got IMD 5, poor entrance to medicine, pretty rare beast, non-white, females who didn't do particularly well in their UK CAT. So they are not the highest flyers academically. 80% of those are likely to apply for GP training. Contrast that with your typical white male applicant to medicine, 10% of whom are likely to apply for GP training. So there's something about the demography of who we get into medicine that factors all the way through into what people want to do when they graduate. Okay, it's not quite hidden curriculum, but it is one of the hidden effects of selection into medicine, including schooling, parenting, etc., etc., etc. The thing that struck me is the 8-fold difference there. Massive. Okay, so the ScotGEM mission, more broadly, is to produce top-quality, adaptable, compassionate, generalist doctors. Our graduates will be entitled to enter any branch of medicine, so it is a very general practice-orientated training for all the reasons I've kind of cited, but actually the students will have to pass the MLA, probably actually in the first cohort. They will get a standard GMC MBCHB degree, and they'll be entitled to practice in any area of medicine. And we are hoping that those who don't want to be GPs will still be very interested in working in rural areas. Indeed, that's part of the basis of the training. We're also doing some interesting things to involve the graduates in healthcare improvement projects actively right from the outset of the programme. This is some data from our applicants this year. So interestingly, the thing in which they felt most strongly about was that we had a course designed specifically for graduates, and they liked case-based learning a lot. Almost no negative things here, which was nice. They weren't telling us things that put them off applying to ScotGEM. And slightly to our surprise, the Scottish Government offers a £4,000 a year cost of living bursary to ScotGEM students, which is returned for a year of service per year of service in the Scottish NHS. And actually, that was not a big factor. So we won't show the Scottish Government that, they might take it away. But that slightly surprised us. So this is my kind of last slide here, which is the kind of tedious bit that's been shown here before, so I didn't want to focus on it. But because of the number of people who are saying they don't know much about ScotGEM, I'm just going to walk you through it because it might inform some of those questions about the role of Dundee and things in the future before we get into some of the more interesting educational innovations. So this is year 1 here on the left, and year 2, and then years 3 and years 4, which is primarily under the auspices of Dundee. These 2 years, the students are primarily matriculated with St Andrews. The way things have panned out is that actually Tayside, who weren't really involved in year 1 ever from the outset, have elected not to be involved in year 2 because of the pressures of managing the existing students and the Scottish Government push to have more training in primary care for existing students. So they've stepped aside from that, which means this year is Fife and St Andrews based, and this year is spread between Fife and St Andrews, Dumfries and Galloway, and NHS Highland, who are our other main clinical partner boards. When they come across into Dundee, well, this is still work that's open to a lot of design, I think it's fair to say, but the intention is that we will use ScotGEM to open up capacity around Fife, Tayside, Dumfries and Galloway and Highland but that capacity may well be shared between ScotGEM students and Dundee students. So there is lots of enthusiasm in the West Coast boards in particular to become more active in the teaching environment. They see that as a way of recruiting staff now, because they can have more interesting portfolio sort of careers for their staff where there's a more formal teaching role, as well as the longer term game that they think they'll be a more attractive place to work if there's a bigger range of jobs. So they're very keen to participate in this. They're most keen on ScotGEM because they think these graduates are most likely to stay there. But actually, we need them to share the capacity, because a lot of this teaching for the ScotGEM students will need to be based in a tertiary teaching hospital, e.g. here, so that they're not rabbits in the headlight when they graduate, having spent a lot of their life in the general practice environment. So I've got this slide. We can come back to this at the end if there are questions around, well, how's this going to work in Dundee then? But this is a few years off, so it's not our main worry at the moment. It's a longer-term ambition and thinking process. What we're interested in at the moment is the detail of some of these more interesting bits, which is how we wish to run case-based learning for ScotGEM and how we're going to try and optimise a CLIC course for these graduate learners. So I'll hand over to my colleague Andrew.
Thanks, John. So I'm going to talk just now about case-based learning. Case-based learning is going to fit mostly into year one of the ScotGEM curriculum. There are 30 weeks of case-based learning in this first year here, and extends into year two when we adopt that distributed model. So there's a further 20 weeks of case-based learning in the first kind of chunk of year two. The first semester we're treating as a kind of introductory block. I'll talk about what a case-based learning week looks like in a minute, but this first period before the Christmas break is very much a first pass of the spiral using the CBL format. So because of our entry requirements, there's the possibility that we might have some arts graduates or graduates who are not from a biomedical science background. So it's a good opportunity, like the principles block on the undergraduate programme here, to get everyone up to the same kind of level. After the Christmas break, we stick with CBL, and we're going to move towards a systems-based or specialties-based approach that allows us to begin to start to apply some of those concepts against cases in more detail. We've got a very tight turnaround assessment period and vacation between years 1 and 2. And when the students come back after their break, hopefully not resit, most of them, they're going to start the life cycle case-based learning stuff as well. And that's when some of the class are going to be still based in St Andrews and Fife, but a quarter of the class may be out at Dumfries, a quarter maybe at Inverness, and we'll go to a more distributed way of learning. So just to give you a flavour of the cases that we're going to go for then, this is semester 1, so that foundations semester. So they're kind of quite broad cases that allow all of the foundation sciences and a lot of the specialties just to introduce themselves to the student. So the aim of these cases is not for students to be experts in obesity at the second week of medical school. That's just not going to happen. So actually, we take muscle weakness, for example, in week 3. It's Duchenne muscular dystrophy. Obviously, our students are not going to become experts in muscular dystrophy in week 3 of medical school, but it does allow us to introduce what is a muscle, how do muscles work, and introduce the musculoskeletal system. And we'll use this semester as a first pass of the spiral. This is the second semester of year 2 by cases, and it allows us to take those principles and drill down a little bit using a more traditional systems-based approach. The reason we've stuck with systems in year 1 only is because it's the only time we have the students physically in St Andrews. So all of the anatomy dissection room activity has to be kind of compressed into that year 1. Before they go into year 2, they put the anatomy down, maybe revisit concepts, but they're going to be out and about, so it'll be harder to deliver that content. So the theory of case-based learning then is when students clump together into small groups, and we're looking at 8 groups for the first year, so maybe groups of 6 or 7. They're going to be led by a generalist clinical mentor, so a GP in the community for 2 days, and then 2 days with the University of St Andrews. And they're going to have general medical experience as a generalist, but they'll have specific training in facilitating case-based learning activities. Each week, those students are going to be provided with a virtual case, the ones from the list we just looked at. And the groups will get together, they'll start talking about the case, they'll think about why it's important, what might we want to learn this week. And then during the week, they will have a series of lectures from foundation scientists, from clinicians. They will do their anatomy pro-section labs. They might do their clinical interactions course that we'll hear about later. And then they'll get back together at the end of the week and wrap that case up. So they'll pitch back to the group, they'll debrief, they'll discuss what they've learned. So this is a more graphic representation of that, and I'm a bit more visual, so this makes more sense to me. At the beginning of the week, the students are introduced to the case in the community. The case just acts as a trigger. So the case, not like in PBL, where the whole case is the be-all and end-all. So if it's not in the case, you don't need to know it. The case drives everything. The case in CBL is actually just a trigger to get them interested, get them discussing, getting them thinking. The most important thing are the collection of 15 learning outcomes that accompany the case. So they're going to be really clearly telling our students what we expect you to know by the end of that week. So, and that's what we assess against. And still in the community, in the GCM groups on that stage, each student might take one or two or three learning outcomes that they have special responsibility for, that they'll focus on during the week. As I mentioned before, the students will then progress through the week with some maybe lectures. They might have their physiology or anatomy practicals, and we're going to get clinicians in from Fife during that block there to really explain the clinical relevance, which often is missing in early years of curriculum. I'm not going to say too much about this stage, but the students will, during that week again, begin to apply a lot of the theoretical knowledge from anatomy, perhaps, in their clinical interactions course. But that will also, and Lisa will talk about this in a moment, bring in a lot more of the comm skills and consultation skills in there too. So they then take all their knowledge and their skills and their communication skills, and they'll take them back out into their community again, back out to the GPs. And the hope there is that we'll be able to find some patients that align with the case, that align with the outcomes, so that they can begin to apply their knowledge in real life. In the practice again, they'll debrief the case, so they'll say what worked, what didn't work, what they've learned. Each student will pitch their learning outcomes back to the group. So that might be a presentation like this. They might present a poster. I've seen in my previous job at Southampton, where they run case-based learning, I've seen board games and models and really, really creative stuff. We've even had rapping and singing to get the learning outcomes across. And anything that's unclear from the week, so from the lectures or from pitching back to the group, anything the group are still not cool with, we've got an electronic mechanism that students can submit questions to a special plenary or a panel session at the end of the week, where they can work with clinicians or with scientists to answer those questions. So that's what a week of case-based learning looks like. We've got 50 of them across years 1 and 2. I could talk another 10 minutes on the evidence behind it, but I'm not going to do that. Lisa's going to talk now specifically about the clinical interactions course.
Okay, so for about the last 3 or 4 months, I've been spending some time developing the clinical interactions course. I'll give you an overview, first of all, of some of the concepts that have underpinned what we've been working on, and then I'll give you an overview of the educational approach and a little bit about the content, and then I'll be really keen to hear your opinions on some of the areas that still haven't been developed yet, that are still in the early stages. So at the centre, the central concept when I've been developing the clinical interactions course is this is a community-facing programme, and the fact that it's community-facing means that we need to make sure that the learners have both the skills, the practical and obvious skills, as well as the metacognitive skills to be able to engage in the community learning that they're going to get, so that they can recognise and seize the learning opportunities that they're going to be exposed to in community, as well as being useful and engaging with the communities they're going to learn. So some of the principles that come out from that are that they need to have integrated skills. So in the Dundee clinical skills programme, students learn consultation skills. That's taught in a particular stepwise fashion by a particular group of tutors, often in a particular geographical location. And then the students experience a separate programme of physical examination and procedural skills, often delivered by a different group of tutors in a different geographical location. For ScotGEM, we wanted to pool those together so that at the very earliest opportunities, the students have got the basic communication and examination skills that they'll need to be able to be confident in their community settings as early as possible. So we're integrating those things and pooling those different things together. The other thing is that we want to make sure that we're really enhancing student autonomy in how we teach and what we teach. We know that students who are autonomous learners who have more intrinsic motivation have better academic success. They have better satisfaction with their learning. Their teachers are often more satisfied with the engagement with teaching and learning. And these individuals who are very autonomous in their learning also have a greater sense of well-being and engagement with their learning experiences. We want the students to be able to recognise and seize the opportunities within the community of practice. We want them to become a useful pair of hands in the community, and that's altered the order in which we've done things. So one example that I'll come back to shortly and talk in a little bit more detail is venipuncture. Venipuncture is one of the skills that we were keen to have very early in the ScotGEM programme, because the students can then become a useful member of the team rather than simply being passive recipients of teaching and learning. And also one of the principles here was to capture the best of both. St Andrews University and Dundee University have got between them an astonishing range of quality resources, and we want to pool on all of those resources. Once something has become a ScotGEM resource, those resources will be made available to both of the parent institutions, both Dundee and St Andrews. And this has got real opportunity. For example, if we write new OSCE stations, which are specifically for ScotGEM, those stations will be made available into the question bank in Dundee. So it will allow us, as we generate new questions and new materials, it will allow us to increase the range and scope of existing materials that we've got. So that was some of the concepts. The educational approach, I don't know, I'll have to look around and see if people begin to glaze over a bit if I talk about the educational approach. We're expecting these learners to be much more mature when they arrive. We expect that the average age will be more, and we expect them to come with a much more diverse group of life skills and experiences. So they should be able to be self-directed. Self-direction, the ability to self-direct, we know that we can measure that. There are some tools that are available to help us have students think about how self-directed they are in their learning, and the GCMs and the students will use those together so that they can really be very clear about their expectation. For those of you who maybe supervise postgraduate students, you may have used similar tools about expectations between supervisors and students. We also know that learners who experience autonomy-enhancing programmes are likely to become more autonomy-enhancing clinicians. And there's even some research evidence that shows that autonomy-enhancing clinicians who've experienced these types of programmes can achieve better sustained weight loss in obese patients and better HbA1c control in patients with diabetes. If I've learnt how to take responsibility for my own learning, I'm more likely to empower my patient to take responsibility, to cooperate with them and to partner with them as they take responsibility for their own health and well-being. We're going to use mastery for learning as an educational approach. I'll say a bit more about that when I come to using some examples, and the importance of feedback. So we're going to build in the opportunity for learners to seek and to have learning conversations. So lots of opportunity for formative feedback. Unsituated learning is just about the students are going to be one full day a week with their GCMs in general practice or in community. And we want them to learn the behaviours, the discourse, and so on, in order to become participants in the delivery of that healthcare in the community of practice. So that's a little bit about the underpinning. In terms of content, I've basically taken 3 years of Dundee clinical skills material from consultation skills, examination skills and procedural skills, and I've moved it into 2 years. Now that might surprise you, it might feel like it's a bit of a squeeze. However, we have 14 extra weeks of curriculum across those first 2 years. The clinical skills sessions will be 50% longer. The group size will be smaller, and the GCMs will have a significant amount of continuity with these students. So the person who teaches the student clinical skills and consultation skills on Tuesday is the same person who will be supervising them practicing those skills on Thursday. So they don't need to spend time working out what the students already know, what lectures they've already had, what their pre-existing knowledge is. They'll already know that student A is good at skill such and such because I watched them doing it and I gave them feedback on it on Tuesday, so they can hit the ground running on Thursday with their GCMs. And you've had a chance to look at that. There's quite an exciting block planned at the end of second year. So between second year and third year is a very intensive 6-week acute care block, and all of the acute care stuff is pretty much going to be in there. The students at that stage are going to do basic life support, they'll do basics, they'll have opportunities to work with paramedic teams, and they'll have an opportunity to work with retrieval as well. In terms of delivery then, some practicalities. Year 1 is going to be primarily clinical skills suite in St Andrews, range of models, mannequins, simulated rail and expert patients there. The students will already be prepared from the material that Andrew's already described to you, and the GCMs will be primarily facilitating this with support from some clinical skills staff and from some of the anatomy clinical demonstrators in St Andrews. And there'll be lots of deliberate practice and feedback, and the opportunity to really develop their skills immediately in the same week. So Andrew mentioned I think Andrew missed the slide. I think he was maybe aware of the time. Andrew was talking about tired all the time as one of the CBL cases, so I thought I would take the same case. The clinical case, tired all the time, they'll have their CBL case, they'll have done their basic science lectures, they'll have had their clinical lectures, they'll have had tutorials, they'll have already done the anatomy that's relevant, particularly anatomy and the venous drainage of the limb. And the click content for that CBL week will be systems inquiry, because that sits so comfortably with tired all the time, which could be a symptom representative of almost any system. So the students that week will learn about the systems inquiry. And the other thing that they're going to do in semester 1 is that they're going to have a session of mastery learning for venipuncture. That will involve them having their preparatory material done. Then when they arrive, they will learn the psychomotor elements of the skill on model arms, as most places and most of you will be familiar with. They'll then have a DOPS, a direct observation and procedural skill, and once they've demonstrated that they've had enough opportunity to rehearse that they have passed or had their DOPS signed off, they'll then move through to a second area where their GCM will supervise them in pairs doing practice on healthy peers. So by the end of that session on venipuncture, we would hope that all of the students would have had an opportunity to practice venipuncture, to have shown that they can do a DOPS, that they've got the right psychomotor skills, they can do things in the right sequence and so on. They'll have then had an opportunity to practice on healthy peers before they go into practice later in that week. So the GCM will then know each individual student's skill level, so they'll be able to then offer them opportunities to practice that in real patients. So that's how CBL translates into one example of a session for CLIC. We're going to use the domain scoring Dundee Assess for OSCEs, and there will also be a number of the skills will be recorded and assessed using Portfolio. It's just another overview, reinforcing what we've already done. St Andrews in the first year, second year, some in St Andrews, some in Inverness and some in Dumfries will continue to work on their consultation and examination skills. There'll be some procedures in there. Then a lot of the acute skills will be in the 6-week acute block. And then the bit that I'm really keen to hear views here as part of our discussion is that we haven't really put very much material down in terms of what fifth year looks like. So it's going to be Dundee Hospital or another secondary care focus, and it'll be based around the ward apprenticeships and so on. And I'm quite keen in the discussion time if any of you would contribute to that. What's good, in your opinion, about Dundee's current fifth year? What are the things that you would change in Dundee's fifth year, if you could, and any suggestions that you might have towards planning for the fourth year of the ScotGEM programme? And for those of you who might be interested, those are some references that I referred to. So I think I'm handing over to Jon and Ellie now to facilitate the discussions that we can have.
Okay. Thank you very much, Lisa. So we're doing well for time. I appreciate that's always a pressure around the grand round slots. I'd just like to open up to the floor really for discussions around first any of the sort of three presentations, myself generally around ScotGEM, Andrew around, well, what's this case-based learning thing all about, how does that work, or Lisa around CLIC and particularly her specific questions around how things might look in final year. Just while you're thinking about your erudite, insightful questions, I would just add that there are kind of two acute care bites at the cherry within ScotGEM. One of the drivers behind that block at the end of second year is to ensure that when students go out into GP-based practices, which will be increasingly remote and rural as we push for additional capacity, we want them to be safe, to be able to be kind of first responders when they're potentially out on a house call and they found someone who's collapsed or unwell, or they need to assess someone who may be septic or whatever it is. So there's a driver there at that basic level to give them that skill set. That is clearly very different to a sort of resuscitation situation in an A&E context, though they might get some of that. So one of the final year blocks that's being very deliberately scoped out for ScotGEM is the Dundee acute care block, which is clearly a very well respected and run block. But there are capacity challenges about squeezing in an extra 55 odd students into that. So I just thought I'd lob that in, and in the meantime I'm hoping we've got some hands about ready to shoot up and give us some ideas and challenges to respond to.
Thanks, Jon. If I could maybe start with you, there's a slight shift in the mission since I last heard the presentation, and I guess I'm slightly sensitised to it because I was reading Sir Lewis Ritchie's report on out-of-hours services in North of Skye yesterday, where he was talking about the need for a much more multi-professional approach to service design. And I think I'm right in saying the mission has shifted to where the student was being prepared for a leadership role, to one that I think now said, and I'm not quite sure of your wording, I can't really remember, but it was help drive change. It was a much more participative model that seemed to be described in the mission to one that I saw earlier. And I just wondered, is that in any way reflected is it just a change of words, or is it actually reflected in what happens to students, the exposure? Because I think they may not be exposed to particularly innovative models of rural healthcare.
It's largely a change of words. There have been some sensitivities around setting up doctors to be leaders all the time, and then so for those interested in interprofessional education, they aren't welcoming the notion that we teach our medics to be leaders from the outset rather than effective members of teams. So I think that's probably why that word got kind of dropped from my memory. But also, of course, there is now a national curriculum under discussion for leadership for undergraduate medics, and that is being assimilated within the Agents of Change kind of program. So a lot of those, what we might loosely call leadership skills, I know that's different from the kind of concept of who's leader of the gang, will be integrated within that process of getting students to work with both general practice in the early years and then hospital teams in the later years in those healthcare improvement projects. Does that make sense? So no, it's still very much there, but the IPE dimension, which like most courses we're struggling to work out how to really bring that alive, is one of the reasons why that's been softened.
As a white, boringly middle-class, Cambridge-educated man.
Did you not apply to general practice?
I have fallen to type and become a secondary care consultant. My wife is white and female and Cambridge educated and is a GP, so we're trying to even it out some way or other. But I was quite surprised by the magnitude of the effect. And it doesn't surprise me that there is the effect.
The effect's been known about for a long time.
What's going on? Why is this happening? It seems strange to me. You say that people are being told they're too clever not to be GPs. I think I'm not clever enough to be a GP. I'm only clever enough to do one little thing, hopefully well, not everything.
But and a lot of people say that. But I think if you look, for instance, at the demographics of applications from Oxbridge and Edinburgh down there, kind of too, and indeed are deliberately setting themselves up as the academic medical school of the north, then that does play in to that dimension. If you look across the board at those who apply to general practice, they are not the academic high flyers. They've got on average lower UK CAT scores. If you look at those who aspire to be GP, so during time at medical school, I think people often just learn quietly where their kind of place is in that. Now, that might be a sense of, I don't think I can achieve because I'm not, bright enough to do membership, perhaps, or it might be, I don't really fancy that. I mean, there's a very different culture in general practice, a much more collegiate, collaborative culture that less aggressively competitive people don't, sit more comfortably with, I think. So I think there's an awful lot of things going on that drive people to make those choices. But they're kind of just a personal take on that, the evidence-based burrowing into that. I mean, in the States, I suppose, there's really interesting information around the fact, and where it's much more ethnically driven. Some of the widening access activities in the States, the so-called pipelines, have been much more driven towards ethnicity than they have towards socioeconomic class. The States doesn't seem to have quite woken up to that. They're not sort of facing that. And one of their celebrations is that BME entrants to medicine are much more likely to work in primary care and in underserved areas, which surprisingly are typically non-white areas of the big American cities. So people, for one reason or another, kind of gravitate back to their community, whether that's in a non-white urban environment or a completely white, rural Scottish environment. There's people are comfortable in different areas. For a whole magnitude of reason, I'm surmising, but I don't think we really know.
Yeah, I'm the. You just beat you to it. I'll talk as I go. I'm the associate postgraduate dean responsible for careers, and as part of what we're trying to do is try to tease out why it is that only 20% of people in foundation want to go on to be a GP. We had a meeting in this very auditorium just a few months ago, and it was far less than 20% of people, more like about 5%.
I just wondered on the same theme, if you take out your ethnicity and sex and you just look at the scoring, is that scoring for application to medical school? What is the difference between GP and secondary care? Yeah,
I'd have to look back at the paper. It's there, but it is far less. That's what I was saying about if you take UK CAT as a non-subject specific intelligence test, and the reason why that's of interest is it is less skewed by social class and schooling than school grades are, as the other kind of denominator that you might use, but it is still skewed. It is still, in fact, white and male UK CAT takers get significantly higher results. So it's driven by social class as well. So the playing field is never level at any point, if you see what I mean. So it's very hard to disaggregate these different factors. But it would be an element of, times 1 times 1.5, not times 8. So that all the factors multiply jointly. We know that non-white medics do less well in their exams. What's really interesting is the people who get into medical school for instance, UK CAT terms are fairly equal, irrespective of skin colour. By the time they come out of medical school, they are already diversifying, and by the time they get into postgraduate exams, that is clearer, and their career options appear to be quite different. And there's, again, another interesting UK CAT study done by some health economists who are looking at how many applications to what specialities different people elect to do, and also whether they make one or whether they make two, in which case general practice is almost always the fallback one, and that is very often ethnically driven. So the Asian doctors will apply for a first choice speciality training, very typically surgeon, disproportionately surgical, plus general practice. The white high flyers go for their chosen thing and don't have a fallback, with a sense that, well, maybe they're confident enough they can get the fallback if they want to, or that's going to succeed. So the application behaviour is subtly different. I must dig out the paper for you, Tom, because that would be, I'm not sure it's been published yet, but that's really interesting stuff that is beginning to look at behaviours in a quite subtle way.
Could I just ask a couple of questions? First, very general. What's the kind of pay differential between a rural and an urban GP? Because I noticed, I guess, people were being put off general practice by pay.
Yeah.
And, whether incentivising, is there a major differential is, I guess, the first question.
It's a really complicated territory because, in general, urban GPs will have a larger list size and therefore they'll have a larger income. But you get to a point where practices are non-viable, so therefore there is a payment scheme that supports a rural general practitioner that isn't proportionate to their workload. So the GP on the Isle of Coll, I know, winter has 130 patients. Not too busy, but still gets paid a salary for being there and being on call 24/7 or 64 days or whatever it is before she gets a break. So you could argue, well, that's really good pay for the work you're doing, and so it's hard to switch. There's also this new GP contract that's been introduced. So the Scottish Government's just guaranteed a minimum full-time equivalent salary of £86,000 for a GP, irrespective of where they are. So that will play to the advantage of some rural practitioners. But not others. As a group, they're losing in that. So the rural GPs just feel they've had another little kick in the teeth, accidentally, by the Scottish Government.
Could I just ask a second question? I guess for the case-based learning, is this based on a validated kind of template, or is it kind of a unique course for ScotGEM? And is there an element of shoehorning? I was interested in the Tired All the Time case where the anatomy of the limb came up, given that I see an awful lot of Tired of the Time cases and don't think I ever consider the limb in that respect.
Yeah, so is this on? Yeah, so case-based learning has quite a long history. It was, I think, probably came out mid-90s or something like that. The first kind of papers evaluating it came through 97, 98, and it's running in kind of this format, but we've obviously tweaked it for our needs in Warwick, Southampton, mainly in graduate entry programs. One thing I didn't get a chance to talk about there was about the amount of free space in the timetable in case-based learning. Very clear weekly learning outcomes and a lot of free time for graduate students seems to work really well. They prefer that slightly less structured approach, and they know what works for them in terms of their learning. You have to do quite a lot of signposting, but that's something that we can manage. I suppose the shoehorning is a bit of an issue with PBL, where the case is the be-all and end-all. With CBL, the case just forms a trigger. So in that Tired All the Time week, the patient ends up with some kind of iron deficiency anemia, I think. But it's actually blood week, and the case is a trigger, and we talk about the physiology of blood and the anatomy of the upper limb and things that in real life you probably don't think much about when you see someone that's tired. Towards the end of year 2, I think there's another Tired All the Time case, and it's thyroid disease, and we think a lot more about endocrinology. So it's the case is a trigger rather than as a curriculum is what we're going for here.
It's blood in circulation and anemia, and the point is that they need a full blood count done. That's the purpose of having venipuncture that week.
Thank you. Yeah. I have them both. I guess a follow-up question, John, and it was really around the IPE side of things. And I was thinking back to perhaps when we used to teach in TCGP 20 years ago, and the consultation, communication skills for medical students where we had patients in were always co-facilitated. So there was a GP who sat in and then somebody from another discipline, and it was to try and give different perspectives on the way students communicated. And I just wonder from an IPE perspective, because, you know, having come through that world and felt the pain of timetabling, of moving students around the system, the shift is actually to mentorship and interprofessional mentorship, and actually having, so I know you've got the generalist clinical mentors, but whether there were mentors from other professions as well to reinforce that, to give that different message, but also, you know, it's emphasising the interprofessional nature of general practice as well. So that's certainly easier logistically to facilitate than moving students around the system.
I think you're showing both of our ages there, Stuart, actually, to be honest.
So, I was a boy.
The day when the students are anchored with their GCM, so there'll be probably 7 students in the first year per GCM. They will have to wrap up the last week's case and launch the next week's case and put a break in there. That's roughly half the day. The other half the day will include a range of different things. So, for instance, picking up on taking blood from real patients. So the GCM might organise a Venipuncture clinic in the surgery, get lots of patients around and take blood from 30 patients that morning. So they're competent at taking blood at the end of that time. An unusual, you know, opportunity for students at that kind of age and stage. Another day, then they might be under the auspices of the practice nurse looking at assessing respiratory patients and spirometry and a respiratory review led by a nurse, midwife, district nurse, all the usual extended primary care team. So without formalising it, you know, here we're bringing you in a nurse so you can do it. It will be integrated within that day, and also within some secondary care experiences in year 2. So if you take, for instance, a case of antenatal care, then there'll be a midwife-led clinic that we would be immersing the students in, because that would be appropriate for their learning needs medically. But the point is, we'd be saying actually midwives do this stuff, so yeah.
Okay, we'll bring things to a close, I think, because it's getting towards 2 o'clock. I think it's interesting that the ScotGEM was, the kernel of the idea was driven because of the need to get more GPs, but we desperately need more psychiatrists. This place needs more surgeons. We need more of everything. And I think, although the trigger was to get more GPs, if it's a good medical school, which I'm sure it will be, it will develop good everything. And hopefully that it's not just a GP churning machine, it's a machine to take graduates who are interested, self-motivated, active learners and turn them into good doctors of all specialities. And I will continue plugging away to see if we can generate more GPs from the current bunch of foundation doctors. And I'll be interested to see how it all goes. So, next week, Gay Sutherland from London coming to talk about nicotine addiction, and I've got a willing volunteer who's going to chair for me, so thanks to Ellie for volunteering. And that's it. So thanks so much to our 3 speakers. Thanks for coming.